Today is the second day of Advanced Cardiac Life Support. In other words, Advanced Cardiac Life Support Part 2. The first, respiratory arrest. Individuals with ineffective breathing patterns are considered to be in respiratory arrest and require immediate attention. Resuscitate individuals in apparent respiratory distress following BLS or ACLS protocols. Respiratory arrest is an emergent condition in which the individual is either not breathing or breathing ineffectively. If someone is breathing ineffectively, it can be agonal or gasping respiration, which can often go unrecognized. So even if the patient has agonal or gasping respiration, they consider as no respiration and act as such. The first and important first step is check the responsiveness of the patient or the victim. Shake and shout, "Are you okay?" Check for breathing for no more than 10 seconds. Time is of essence. If not breathing or insufficiently breathing, continue airway. Call EMS, Emergency Medical Services, and get AED if it is available close by. Send someone to call for emergency medical services. Send someone to get an automated external defibrillator. If you are the only provider, activate EMS and get AED. Since we all have cell phones, you can activate emergency medical services by dialing your cell phone. If there is no pulse, check for shockable rhythm with AED. If shockable rhythm, stand clear when delivering shocks. Provide CPR between shocks, starting with chest compressions. If there was a pulse, start rescue breathing, one breath every 5 to 6 seconds or 10 to 12 breaths per minute. Check pulse every 2 minutes. If there is no pulse, start CPR and give compressions, 30 compressions and 2 breaths afterwards. The rate of compression has to be 100 to 120 compressions per minute. These are all the ACLS survey, ABCDs of ACLS survey. Number one, maintain airway in unconscious patient. All unconscious patients have compromised airway. Remember that. Consider advanced airway if you are proficient in it. Monitor advanced airway if placed with quantitative waveform capnography. If you do not have one, make a habit. You have that access to capnography that tells you, number one, your intubation is right. Number two, how effective your resuscitation efforts are. Give 100% oxygen. Assess effective ventilation with quantitative waveform capnography. Do not overventilate. Evaluate rhythm and pulse. Defibrillation or cardioversion needs to be done, depends on the rhythm. Obtain IO or IV access. Give rhythm specific medications. Give IV or IO fluids if needed. Identify and treat reversible causes, which we are going to talk later on in this seminar. Cardiac rhythm and patient history are the key to the differential diagnosis. So, what kind of airways? One, advanced, basic. So, another one. The basic airways everybody should be proficient in, not only the doctors, nurses, respiratory therapists, paramedicals, and including public. So teaching them is very important in saving the patient's life. Mouth to mouth nose, bag and mask ventilation, especially for paramedics, oropharyngeal airway, and nasopharyngeal airway, everybody should be proficient in. Advanced airways need some skill sets. Most of the time, we do endotracheal tube or laryngeal LMA. If you have esophageal tube and laryngeal tube, one can use as an advanced airway. Most often we end up doing just endotracheal tube. It not only it provides an airway, it also protects the airway. CPR is performed with the individual lying on their back. The gravity will cause the jaw, tongue, and the tissues of the throat to fall back and obstruct the airway. So, in any unconscious individual who is lying on his back, the airway compromise is the rule. So, important thing is open the airway so that the even your mouth to mouth breathing or bag mask ventilations will get into the lung. The airway rarely remains open in an unconscious individual without external support. So, first step is open the airway, lifting the chin upward while tilting the forehead back. Head tilt and chin lift. As long as there is no suspicion of spinal cord injury. If you suspect spinal cord injury, you do jaw thrust maneuver, which we talked about in BLS course. The goal is to create a straighter path from the nose to the trachea. Another important part, this picture shows head tilt and chin lift that opens the airway. Do not overventilate, giving too many breaths per minute or too large volume per breath. Both can increase intrathoracic pressure, decrease venous return to heart, diminish cardiac output, as well as predispose individuals to vomit and aspirate gastrointestinal contents. The first one is pulseless ventricular tachycardia and ventricular fibrillation. These are all the shockable rhythms in advanced cardiac life support. Pulseless ventricular tachycardia and ventricular fibrillation are life-threatening cardiac rhythms that results in ineffective ventricular contraction. In case of ventricular fibrillation, rapid curing of ventricular walls that prevents them from pumping. Ventricular tachycardia, ventricular contraction is so rapid, there is no time to refill, resulting in undetectable pulse. ACLS management of pulseless VT and VFib are essentially the same. You treat VFib and pulseless ventricular tachycardia the same. AED reads and analyzes the rhythm and determines if a shock is needed. AED is programmed to only prompt the user to defibrillate pulseless VT and ventricular fibrillation rhythms. The machine does not know if the individual has pulse or not. So it is very important before you shock the patient, make sure the patient doesn't have the pulse. If the patient has a pulse, then do not use the AED. Shock should only be delivered for pulseless VT and ventricular fibrillation. Antiarrhythmic drugs and drugs to support BP may be used in these two rhythms. So what are the rules for the ventricular fibrillation? There is no regular shape of the QRS complex because all electrical activity is disorganized. The rate appears rapid, but the disorganized electrical activity prevents the heart from pumping. There are no P waves. There are no PR intervals. The ventricle complex varies. A typical picture of ventricular fibrillation looks like it. Second, ventricular tachycardia. PR intervals are usual but not always regular. The atrial rate cannot be determined. Ventricular rate usually between 150 and 250 beats per minute. QRS complexes are not preceded by P waves. There are occasionally P waves in the strip, but they are not associated with ventricular rhythm. There are no PR intervals because there is no P waves. QRS complex measures more than 0.12 second. The QRS will usually be wide and bizarre. It is usually difficult to see a separation between QRS complex and T waves. The typical VTAC looks like it. Third rhythm is torsades. What are the rules for torsades? There is no regularity. The atrial rate cannot be determined. Ventricular rate usually between 150 to 250 beats per minute. There are no P waves, no PR intervals. The ventricular complex varies. As you can see, the torsades typically look like that. Now you have seen ventricular fibrillation, ventricular tachycardia, and dorsage.
அந்த இடத்துல ஸ்டார்ட் வீடியோ அவங்க ஆட்டோமேட்டிக்கா இருக்கும் இந்த கிளாஸ் அவங்க
Ventricular fibrillation and pulseless ventricular tachycardia are both shockable rhythms. The AED cannot tell if the individual has a pulse or not. So before we shock, make sure the patient does not have a pulse. The second group is called pulseless electrical activity and asystole. PEA and asystole are related cardiac rhythms in that they are both life-threatening and unshockable cardiac rhythms. Very important to remember. Always ensure that the reading of asystole is not a user or technical error. Sometimes the connection is not good and the pad which was placed is not sticky enough and the machine is on. Though all needs to be checked, but not by the physician or those who are doing CPR. Somebody in the team should make sure that is being intact while you are calling it as asystole. PEA is one of many waveforms by EKG, including sinus rhythm. The EKG may read sinus rhythm, but if it is pulseless, that is called pulseless electrical activity. PEA may include any pulse waveform with the exception of ventricular fibrillation, tachycardia, or asystole. Hypovolemia and hypoxia are the two most common causes of pulseless electrical activity. Very important, needs to be dealt with right away. If you have an IV, you can push the fluids and give oxygen through the regular nasal cannula or through the advanced airway. So rules for pulseless electrical activity and asystole. The flat line reveals no electrical activity, as you can see here, whereas PEA reveals organized or semi-organized electrical activity in the absence of palpable pulse. Very important thing I wanted to emphasize here, when you see the flat line, do not declare them death till you do CPR and follow the guidelines, at least for 20 minutes before you declaring them death. Just 2 days ago, one day before yesterday, I had a patient with asystole. After like 15 minutes of resuscitation, we got return of spontaneous circulations. I do not know what would be the neurological outcome. Nevertheless, the patient was not dead. Anyway, the organized any rhythm without a pulse is called pulseless electrical activity. Any rate or no rate, possible P waves, possible PR waves, or non-detectable, possible QRS complex, or non-detectable. The other group is just flatline, asystole. There's no rate, no P waves, no PR interval, no QRS complex. Always verify the reading of asystole is not equipment failure. Make sure pads make good contact with the individual. All cables are connected. Gain is set appropriately and the power is on. It's very important before you make calling it as asystole. Hypovolemia and hypoxia are easily reversed and are the two most common causes of pulseless electrical activity. So what are the other causes? There are 6H and 6Ts as a reversible causes. Easy to remember. As I said, hypovolemia and hypoxemia are the most two common causes of pulseless electrical activity. Without saying, when you have a hypovolemia and hypoxia, you will have hydrogen ion concentration, which is called acidosis. Sorry. And hypo or hyperkalemia, hypoglycemia automatically checked. So out of 6, 4 automatically checked, and of course, 5th is 2, hypothermia. So only hypo and hyperkalemia needs the lab investigation. Even that can be detected by the EKG findings. Then 60s, tension pneumo, tamponade, toxins, coronary thrombosis, pulmonary thrombosis, or unrecognized trauma. Trauma will be obvious, and the ACS, we are going to talk about it. And urine toxin, you need to have a high index of suspicion and also other signs and symptoms. So when you have unshockable rhythms, which are pulseless electrical tachycardia and asystole, epinephrine is still the best choice. Earlier epinephrine use has been associated with return of spontaneous circulation in patients. When you have a PEA and asystole, start early epinephrine along with high quality CPR. In a shockable rhythms, which are ventricular fibrillation and pulseless ventricular tachycardia, prioritize defibrillation and CPR initially. When we do a CPR, give a high quality CPR. Give epinephrine if initial attempts with the CPR and defibrillations are not successful. This is algorithm, adult cardiac arrest algorithm. Next week, we are going to talk about pediatric advanced life support, part 1, subsequently part 2. Just stay, if you have any questions, just wait for the next one. I just want to emphasize one thing. If you are a private practitioner or working in the hospital, who is going to come through the door, you do not know. If somebody comes with the unresponsiveness, with no pulse, you should be able to tackle them. So be proficient in basic life support, be proficient in advanced cardiac life support, and also pediatric advanced life support. Very important, not only to you, for your whole team, in order to provide the best care possible. Okay, number 1, activate emergency response. Start CPR, give oxygen, and attach monitor and defibrillator. If you find a shockable rhythm, the shockable rhythms are ventricular fibrillation and pulseless VTAC, administer shock, and CPR for 2 minutes, get access. If it is no shockable rhythm like pulseless electrical activity or asystole, give epinephrine as soon as possible. So when there is aftershock, give CPR for 3 to 5 minutes. Consider advanced airway and capnography at that time. And check every 2 minutes for shockable rhythm and shock, and continue high quality CPR. In those patients with no shockable rhythm, CPR, keep giving epinephrine every 3 to 5 minutes. We typically do every 3 minutes. Consider advanced airway and capnography, and keep looking for shockable rhythm. When you get a shockable rhythm, it is easy to reverse them back to sinus rhythm, and continue high quality CPR. There are no signs of return of circulations, and keep doing it. I have done when to stop the CPR in our ACLS part 1. Please refer to that YouTube video. So adult cardiac arrest should have high quality CPR. What is high quality CPR? Push hard and fast. Push hard means push 2 to 2.4 inches or 5 to 6 centimeter. Fast means rate of 100 to 120 beats per minute. And allow chest recoil. Do not rest or lean on the chest in between the compressions. Do the hard push and let the chest recoil complete fall. That allows the blood flow back to the heart. Minimize interruptions. The interruption between one to another or between the shock and CPR should not exceed 10 seconds. Do not overventilate. If you have a capnography, make sure the PCO2 between 35 to 40. If no advanced airway, give 30 compressions and 2 breaths. Quantitative waveform capnography. If entire COT is less than 10, attempt to improve CPR quality. That means the high quality CPR is not performed. So that way, having a capnography will tell you how good CPR being provided in that patient. Second is shock energy. Right now, we use only biphasic. Once upon a time, almost 20 years ago, we used to use monophasic. That has been completely not there in any hospital in the United States. Anyway, biphasic delivery of energy during defibrillation has been shown to be more effective than older monophasic waveforms. Follow manufacturer recommendation. Initial dose with biphasics is 120 to 200 joules. If unknown, use the maximum dose available. Very important. Second and subsequent doses should be equivalent or higher doses. What is return of spontaneous circulation? Return of pulse and blood pressure. Sudden sustained increase in end-tidal CO2, typically more than 40, indicates the circulation is good. Spontaneous arterial pressure waves with intra-arterial monitoring. Advanced airway means supraglottic advanced airway or endotracheal intubation. Absolute placement confirmation needs to be done by auscultating the epigastric region and positive bilateral chest auscultation and vocal cord visualization when you are intubating and quantitative end-tidal CO2. And when you do that, when you give 10 breaths per minute with continuous chest compression. So when you do an advanced airway, the person who is proficient in advanced airway needs to do the advanced airway insertion. Drug therapy, epinephrine, the dose, the IV and IO dose are same, 1 milligram as soon as possible and repeat every 3 to 5 minutes. As I said, our practice is every 3 minutes. Amiodarone, first dose is 300 milligram bolus, second dose is 150 milligram. Lidocaine, first dose 1 to 1.5 milligram per kilogram, second dose 0.5 to 0.75 milligram per kilogram. And always look for the reversible causes, very important. Address them early, it reverses the whole course. Hypovolemia, hypoxia, acidosis, hypothermia, hypo or hyperkalemia, and hyperglycemia. And cardiac tamponade, toxins, tension pneumothorax, thrombosis, pulmonary and coronary, and trauma. The post-cardiac arrest also very important, as similar to or more than BLS and ACLS. If an individual has return of spontaneous circulation, start post-cardiac arrest care immediately. The BLS and ACLS are meant to save the individual. The post-cardiac arrest care is meant to optimize ventilation and circulation, preserve heart and brain tissue and function, and to maintain recommended blood glucose levels. The recovery and the outcome depends on the post-cardiac arrest care. These are all the acronyms used for post-cardiac arrest care. Vital signs, especially checking blood pressure, delivering oxygen, suspected myocardial infarction, and do we need to send them to chest pain center, and do they need an IV fluids, do they need drip, and targeted temperature management. It goes by the acronym called VOMIT. Airway management. Early placement of advanced airway is needed. Manage respiratory parameters. When you do an advanced airway, keep 10 breaths per minute while you are doing CPR, and pulse ox goal, saturation goal 92 to 98, and CO2 goal 35 to 45, and waveform capnography or capnometry to confirm endotracheal tube placement. Blood pressure support and vasopressors, obtain EKG. Consider blood pressure support in any individual. It is for adult. Systolic blood pressure less than 90 or MAP less than 65. Unless contraindicated, give IV fluids, either normal saline or lactate or ringers needs to be given. When blood pressure is very low, consider pressors. Vasopressors and inotropes are the medication to create vasoconstriction, increase the cardiac contractility. Consider the following drugs: dopamine, norepinephrine, or the process of choice if the patient is not in cardiac arrest. If the patient is cardiac arrest, goes directly to epinephrine. Vasopressin and phenylephrine are the second agents after dopamine and norepinephrine in non-cardiac arrest patient. Titrate the infusion rate to maintain the desired blood pressure. The post-cardiac algorithm to prevent hyperoxia, hypoxemia, and hypotension. Targeted temperature management is the only documented intervention that improves or enhances brain recovery after cardiac arrest. It's very important. It is used only in unresponsive individuals and should be continued for at least 24 hours. So how cool the temperature should be? 32 to 36 degrees centigrade or 89.6 to 96.8 degrees Fahrenheit. It needs to be continued for 24 hours. Use a cooling device with a feedback loop. What does that mean is you fix the temperature. So when the temperature goes above, it kicks in. When temperature goes down, it stops automatically so that it maintains the temperature between 32 to 36. This is a post-cardiac arrest algorithm. Avoid excessive ventilation. Keep the PaCO2 to between 35 to 45 and give 1 to 2 liters of normal saline or lactate ringers unless otherwise there is a contraindication. Epinephrine, the dose you can use is 0.1 to 0.5 mics per kick per minute. Once we reach the return of spontaneous circulation, and if the patient was not have an advanced airway, place an endotracheal tube, 10 breaths per minute, SAT 92 to 98, and CO2 35 to 45. Manage hemodynamic parameters. Keep the blood pressure more than 90, MAP more than 65. Obtain 12 leakage is very important in adults because that will kind of separate STEMI from non-STEMI patients or unstable cardiogenic shock. Consider if there is emergency cardiac intervention needed in STEMI, unstable cardiogenic shock, or mechanical circulatory support required. Dopamine dose use is 5 to 10. Norepi recommended is 0.1 to 0.5 mics per kick per minute, and look for the reversible causes and address them right away. And follow commands, whether the patient is able to follow commands. If the patient cannot follow commands, that means the patient is comatose, start targeted temperature management, obtain brain CT, and EEG monitoring is very important to make sure there is no ongoing seizures, and other critical care management like glucose and all those stuff needs to be checked. If the patient is awake, evaluate and treat rapidly the reversible etiologies, which we mentioned before, and involve the expert consultation and continued management. The other is bradycardia, how to identify and manage bradycardia. Bradycardia is defined as heart rate less than 60 beats per minute. Individuals with excellent physical shape often have sinus bradycardia. It's called asymptomatic bradycardia. In symptomatic bradycardia should be treated with ACLS survey. Very important to remember. If bradycardia is asymptomatic but occurs with an arrhythmia listed below, which we are going to discuss, obtain consultation from cardiologists experienced in treating rhythm disorders. What are the symptoms of bradycardia? Shortness of breath, altered mental status, pulmonary edema or congestion, weakness, dizziness, and lightheadedness. The rules for sinus bradycardia: odd intervals are regular. The rate is less than 60 beats per minute, but usually more than 40 beats. There is a P wave before every QRS complex. PR interval measured between 0.1 to 0.2. QRS complex is less than 0.12. Rhythm is sinus, but the heart rate is slower. Sinus bradycardia. The second group is called first degree heart block. RR intervals are regular, overall rhythm is regular. The rate depends on the underlying rhythm. There is a one P wave in front of every QRS complex. The P wave appears uniform. It measures the PR interval is more than 0.20 seconds. And QRS complex is normal, meaning less than 0.12 seconds. So the first degree heart block is just prolonged PR interval. Prolonged means more than 0.20 seconds. The third category is type 1 AV block. The type 1 AV block, RR interval is irregular, but it is usually patterned to it. RR intervals gets longer as the PR intervals get longer. The ventricular rate is usually slightly lower than the atrial rate due to some atrial beats not being conducted. The atrial rate is usually normal. The P waves are upright and uniform. Most complexes will have P wave in front of the. However, there will be some P waves that do not have QRS complex. Most of them will have a P waves in front of the QRS complex. Some don't. PR interval progressively get longer until there is a dropped QRS complex. QRS complex is normal. So in this one, the PR interval progressively longer until there is a dropped QRS complex. The secondary heart block, type 2, otherwise called Mabitz type 2. If there is a consistent conduction ratio, then the RR intervals will be regular. If the conduction ratio is not constant, the RR interval will be irregular. The atrial rate is normal, the ventricular rate is slower, usually half to one-third slower than the atrial rate, meaning all the P waves are not conducted into the ventricles. The P waves are upright and uniform. There is not a QRS following every P wave. That means some of the P waves are not conducted into the ventricle. The PR interval can only be measured on conducted beats. It is usually constant across the strip. It may or may not be longer than normal PR interval. The QRS complexes are normal. That means here, not all P waves are followed by QRS complex. The third degree heart block is RR interval is regular, PP interval is also regular, but they do not follow each other. In normal sinus rhythm, P wave followed by QRS complex. Here, P wave marches different rhythm and ventricle rate is marches a different rhythm. The atrial rate is regularly 60 to 100. The rate of QRS complex depends on the focus. If the focus is ventricular, the rate is 20 to 40. If the focus is junctional, the rate will be higher, 40 to 60. The P waves are upright and uniform. There is not a QRS following every P wave. The PR interval can only be measured on a conducted beats and usually constant across the strip. It may or may not be longer than a normal PR interval. Interval may be normal, but is more likely to be prolonged in third degree heart block. It is a review of the symptomatic bradycardia. Sinus bradycardia, only the rate is low, otherwise everything else is good. The first degree AV block, there is a prolongation of the PR interval, meaning more than 0.2 seconds. Type 1 second degree AV block, PR interval progressively increases until QRS complexes drop. Type 2 secondary AV block, the constant PR intervals may be prolonged before a random QRS is dropped. Third degree AV block, P waves and QRS complex are not coordinated with each other. How do you deal with the adult bradycardia? Number one, assess the signs and symptoms, especially when the heart rate is less than 50 beats per minute. Identify and treat the underlying cause. Maintain the airway. Assess breathing if necessary. If hypoxemic, give oxygen. Monitor, look for rhythm apart from what is the type of bradycardia. Type 1, type 2, type 3. Have an IV access and check the blood pressure and pulse ox and have a 12-lead EKG done. Consider hypoxic and toxicology causes. When you do the ventilation, make sure do not overventilate and keep the CO2 between 35 to 40. And the medication used for adult bradycardia is atropine. The dose you give 1 milligram bolus and repeat every 3 to 5 minutes up to 3 milligram. If the bradycardia persists, you can start dopamine IV infusion, the dose of 5 to 20 mics per kg per minute, epinephrine 2 to 10 mics per kg per minute. If there is persistent bradyarrhythmia causing hypotension, altered mental status, shock, chest pain, acute heart failure, go for transcutaneous pacing, dopamine infusion, or epinephrine infusion. If there are no symptoms, monitor and observe. At that point, consider specialist consultation and transvenous pacing. Initially, you can do transcutaneous pacing using the pads you already have from AED. Next is tachycardia. Tachycardia is defined as the heart rates greater than 100 beats per minute. Tachycardia has shortened the relaxation phase. It causes two problems. One, ventricles are unable to fill completely, causing decreased cardiac output. Second, the coronary arteries does not receive less blood, causing supply to the heart to decrease. Again, affects the cardiac output. Tachycardia is classified into stable or unstable. The heart rate greater than or equal to 150 beats per minute usually cause symptoms. Unstable tachycardia always requires prompt attention. Stable tachycardia can become unstable. Because it is stable at one point doesn't mean that it will remain stable. So make sure you address the underlying cause. What are the symptoms of tachycardia? Hypotension, sweating, pulmonary edema and congestion, jugular venous distension, chest pain, discomfort, shortness of breath, weakness, dizziness, lightheadedness, and altered mental status. The individual is unstable, provide immediate synchronized cardioversion. Very important. Unstable tachycardia, synchronized cardioversion. The individual's tachycardia producing hemodynamic instability and serious symptoms. Or the symptoms, pain and distress of acute myocardial infarction producing tachycardia. Second, assess the individual's hemodynamic status and begin treatment by establishing IV, giving supplemental oxygen, and monitoring the heart. The heart rate of 100 and 130 beats usually is a result of underlying process, often represents sinus tachycardia. If sinus tachycardia, goal is to identify and treat the underlying systemic cause. The heart rate is more than 150 beats per minute may be symptomatic. Higher the rate, the more likely the symptoms are due to tachycardia. These numbers are just for adults. In children, different rates, which we will discuss in subsequent seminars. Other important part is assess the QRS complex. If any point you become uncertain or uncomfortable during the treatment of stable patient, seek expert consultation. Adenosine may cause bronchospasm, especially when you are treating supraventricular tachycardia. If the patient has underlying asthma, beware. That doesn't mean that you don't give, but beware. Synchronized cardioversion is appropriate for treating wide complex tachycardia of unknown type. Prepare for synchronized cardioversion as soon as wide complex tachycardia is detected. Tachycardia review. Regular narrow complex tachycardia, otherwise called supraventricular tachycardia. Attempt vagal maneuvers, 12 EKG, expert consultation, give adenosine 6 milligram, rapid IV, very important. There is no conversion, double the dose to 12 milligram. Irregular narrow complex tachycardia, probable AFib, 12 EKG, and control the rate with diltiazem 15 to 20 milligram, which is 0.25 milligram per kilo over 2 minutes, or beta blockers. Third category is regular wide complex tachycardia. That could be ventricular tachycardia. 12 EKG, expert consultation, convert rhythm using amiodarone 150 milligram IV over 10 minutes. Perform elective cardioversion. The dose of amiodarone is different if you really look at it. In cardiac arrest situations, you use 300 followed by 150. Irregular wide complex tachycardia, obtain 12 lead EKG, consider expert consultation. Consider antiarrhythmic. If there is a torsades, give max sulfate 1 to 2 gram IV push, followed by 0.5 to 1 gram over 60 minutes. See, these cardiac rhythms needs to be identified promptly and act immediately. So what are the criteria for sinus tachycardia? Similar to bradycardia, sinus bradycardia, sinus tachycardia has the same rules, except the heart rate is higher. Oral intervals are regular. Rate is over 100 beats per minute, usually less than 150 beats. The P wave in front of every QRS complex, P waves appear uniform. PR interval normal, 0.1 to 0.2, and QRS complex normal. Only the heart rate is higher. The second category is atrial fibrillation, irregular narrow complex tachycardia. RR intervals are irregular, therefore overall rhythm is irregular. The ventricles conduct from different atrial foci causing the irregularity. Atrial rate usually exceeds 350. If the ventricular rate is between 60 and 100 beats, this is known as controlled AFib. If the ventricular rate is more than 100, it is considered rapid ventricular response AFib, also known as uncontrolled AFib. Due to the atria firing so rapidly from multiple foci, there are no obvious P waves in the rhythm. The baseline appears chaotic because the atria are fibrillating, therefore no P waves are produced in front of the QRS complex. Because there are no P waves, PR interval cannot be measured. The QRS complex is usually narrow, meaning it's less than 0.12 seconds. Atrial flutter. Atrial rate is regular. The ventricular rate will usually be regular, but only if the AV node conducts the impulse in a consistent manner. Otherwise, the ventricular rate will be irregular. The atrial rate normally 250 to 350. Ventricular rate depends on the conduction through the AV node to the ventricles. The P wave will be well defined and have sawtooth pattern to them. Due to the unusual configuration of P waves, the interval is not measured with the atrial flutter. The QRS is normal, which is less than 0.12 seconds. So how do you approach adult tachycardia? Number one, assess signs and symptoms. The heart rate more than 150 beats per minute. Identify and treat the underlying cause. Start with the airway. Assess breathing. If there is hypoxemia, give oxygen. Cardiac monitor to identify the rhythm. What is the cause? Whether it is AFib, atrial flutter, sinus tachycardia, or SVT. Monitor blood pressure and pulse oximetry, IV access, and 12-lead EKG. So synchronized cardioversion joules, narrow, regular, complex, 50 to 100 joules. Narrow, irregular, 120 to 200 joules. If you have monophasic, 200 joules. Wide, regular, 100 joules. Wide, irregular, use defibrillation dose, not synchronized. Antiarrhythmic infusion for stable, wide QRS tachycardia. Adenosine dose 6 milligram, rapid IV push. There is no response. Double the dose to 12 milligram. Procainamide, one can use 20 to 50 milligram per minute until arrhythmia is suppressed or hypotension ensues, or QRS duration more than 50% or maximum doses 17 milligram per kilogram given. Maintenance infusion of procainamide is 1 to 4 milligram per minute. Avoid if there is a prolonged QT interval or congestive heart failure. Amiodarone, that is the most go-to medications after adenosine. Initial dose is 150 milligram over 10 minutes. Repeat as needed if VT recurs. Maintenance infusion 1 milligram per minute for first 6 hours. Sotalol 100 milligram over 5 minutes. Avoid if there is a prolonged QT. Since there is the limitation on QT intervals, so adenosine followed by amiodarone is the best way to do. When there is a persistent tachyarrhythmia causing basically symptomatic tachyarrhythmia, hypotension, altered mental status, signs of shock, chest pain, acute heart failure, consider cardioversion. When you do a cardioversion, consider sedation, consider adenosine if regular narrow complex tachycardia is present. If there are no symptoms, look at the QRS complex. If it is more than 0.12 second, meaning wide QRS complex, consider adenosine. If it is regular and monomorphic, consider antiarrhythmic infusion, which we discussed, and consider expert consultation. If there is no wide QRS complex, no symptoms, vagal maneuvers, adenosine, beta blockers, calcium channel blockers, and consider consultation. This is for adults. In children, they're a little different. We will discuss later on in subsequent seminars. The other important, the clinical symptom complex we often encounter is acute coronary syndrome. There are three kinds: unstable angina, non-STEMI, and STEMI. The symptoms could be crushing chest pain, shortness of breath, pain that radiates to jaw, arm, or shoulder, sweating, and or nausea or vomiting. Not all individuals with ACS will present with the classic symptoms like what we discussed, especially in women and diabetics. Sometimes symptoms may be very subtle. Every individual with these symptoms should be evaluated immediately. Group into two. If the patient is unconscious, begin with BLS survey and follow the appropriate pathway for advanced care as we have discussed. If the individual is conscious, proceed with the pathway below. This is pre-hospital intervention. EMS stands for Emergency Medical Services. Start oxygen. Titrate needed to keep the saturation 94 to 99. Give aspirin if there is no allergy. The dose is 160 to 325 milligram to chew. Avoid coated aspirin. Ideally, baby aspirin is the aspirin of choice. Nitroglycerin, give 0.3 to 0.4 milligrams sublingual. Spray 2 doses at 3 to 5 minute interval. Do not use if the systolic blood pressure is 90, or do not use if there was consumption of phosphodiesterase inhibitors like Viagra taken within the last 24 hours. Next is give 1 to 5 milligram IV morphine if the symptoms are not relieved by nitrates. Monitor blood pressure closely because morphine can drop the blood pressure. Get 12 lead EKG, evaluate for MI. Does the patient has ST elevation, ST depression, or poor R wave progression? Have at least 2 large gauge IV in both antecubital fossa. Take to PCI center if probable STEMI. The STEMI patients needs to go to the place where they can do percutaneous intervention. Activate ACS protocol at the hospital. So this all needs to be done even the patient before the patient goes to the hospital itself. The symptoms of infarction or ischemia. EMS assessment, support ABCs. That always comes first. Prepare for CPR and defibrillation. Give aspirin, morphine, nitroglycerin, and oxygen as we discussed earlier. Get 12 lead EKG. If there is an ST elevation, that means STEMI, notify hospital, note first medical contact and onset time. Hospital should prepare to respond to STEMI. If pre-hospital fibrinolysis, use fibrinolytic checklist, which we are going to discuss. Second, EMS assessment, check vitals, IV access, perform PIC history and physical exam, complete fibrinolytic checklist, check contraindications, obtain preliminary cardiac marker levels like troponins, electrolytes and coax studies, obtain portable chest x-ray. It should need to be done real quickly, 30 minutes. This patient's time is very important. If the oxygen saturation is less than 94, start oxygen, 4 liters per minute, regular nasal cannula, aspirin, baby aspirin, not coated aspirin, nitroglycerin. And when you do that, make sure that blood pressure is more than 90, morphine, if the pain is not relieved by nitroglycerin. Again, and morphine can drop the blood pressure, just make sure the blood pressure is supported. So when you get the EKG, it grouped into 3 groups. One, STEMI, another one is non-STEMI, another one is unstable angina. When there is an ST elevation or new left bundle branch block, high possibility for injury, that means STEMI, begin adjunctive therapies, do not delay reperfusion. If the answer time is less than 12 hours, reperfusion goals, patient and center-defined therapeutic criteria, fibrinolysis needs to be given less than 30 minutes, and PCI in less than 90 minutes. It's very important. Once you make the diagnosis, STEMI, that's the reason it is recommended to get the EKG by the paramedic themselves and inform the hospitals so that they are ready for percutaneous intervention. If the patient does not have STEMI, meaning non-STEMI, the ST depression or dynamic T wave inversion, then elevated troponin in high-risk patient, early invasive strategy, ventricular tachycardia, signs of heart failure, hemodynamic instability, refractory ischemic chest comfort, persistent recurrent ST elevation, especially if you have all those things, then you start heparin, nitroglycerin, Plavix, consider beta blockers, and glycoprotein 2B and 3A inhibitors. So different path based on the EKG itself, and also based on if the invasive strategy is not possible because of underlying issues. The third category is T wave changes, ST segment, but it's not consistent with STEMI or unSTEMI, STEMI or non-STEMI. Admit to ED chest pain unit, check the numbers, cardiac marker numbers, troponin, and continuous ST segment monitoring, repeat EKG monitor, non-invasive diagnostic test. If it develops elevated troponins and clinical for high-risk factors, EKG changes consistent with ischemia, push them into non-STEMI category and treat with heparin, nitroglycerin, Plavix, and other beta blockers. Even those patients with unstable angina, physiologic testing shows abnormal diagnostic. Again, they will push into non-STEMI group. If they are good with everything else, discharge and follow up with cardiologist or primary care. Next group is stroke. Stroke is a condition in which normal blood flow to the brain is interrupted. There are two kinds of stroke. One is ischemic, which is vast majority, 87%. Another one is hemorrhagic, 13%. The symptoms of ischemic and hemorrhagic strokes are similar. That is a catch. However, the treatments are completely different, which we are going to talk about. This is before the hospital. Emergency medical services needs to give oxygen, keep the saturation 94 to 99. Check glucose. Sometimes hypoglycemia can mimic acute stroke. Get the history and make sure when he was completely normal or when the symptoms started. Very important, especially in doing percutaneous intervention or not. Determine the patient deficit, gross motor, gross sensory, and cranial nerves. Institute seizure precautions. If you have Keppra or Ativan, go ahead and start that. And they need to have 2 large gauge IVs in antecubital fossa and inform the stroke center immediately so that they are ready. The symptoms of strokes are as follows: weakness in arm, leg, or face, vision problems, confusion, nausea or vomiting, trouble speaking or forming the correct words, problems walking or moving, severe headache, especially in hemorrhagic type. Before giving anything, medication or food by mouth, you must perform a bedside swallow screening. Sometimes they may not be able to swallow. All acute stroke individuals are considered NPO on admission. The goal of stroke team, emergency physician or other experts should be assess the individual with suspected stroke within 10 minutes of arrival in the emergency department. Time is very critical, similar to acute coronary syndrome. The CT scan should be completed within 10 to 25 minutes of the individual arrival in the emergency department and should be read within 45 minutes. I have done an adult stroke and pediatric stroke in 2 separate seminars that clearly delineates and what time frames, what investigations needs to be done. At 10 minutes of arrival, general assessment, get a CT scan without contrast. That differentiate ischemic versus hemorrhagic. 25 minutes of arrival, CT scan without contrast, neurological assessment. That means NIHSS score, the stroke score needs to be done by that time. CT scan needs to be done within 45 minutes, most of the time right away. 60 minutes of arrival, Evaluate criteria for use, administer fibrolytic therapy, otherwise called clot buster. Fibrinolytic therapy may be used within 3 hours of onset of symptom, some cases 4.5 hours in some cases. 180 minutes of arrival admission to stroke unit. So within 3 hours, they need to get everything done and got admitted in the stroke unit. This is emergency department. Complete EMS, emergency medical services care, stroke, targeted stroke evaluations. There is a concept called FAST. Use that one, phase, drop, and all this stuff. And they establish the symptom onset time, CT scan stat, 12 EKG, check glucose, and contact stroke team. All need to be done most of the time, even before the patient comes to the hospital. Then at that time, it's grouped into two. If the patient has a hemorrhage in the CT scan, which is only 13%, consult neurosurgery, coagulation panel, type and screen, and goes in a different pathway. The vast majority are ischemic, as we said, 87% of them are. Confirm the symptom onset, perform targeted neurological exam, the stroke scale, and complete fibrinolytic checklist. So what are the inclusion criteria? So you start from there. When the symptom onset within last 3 hours, 18 years or older, ischemic stroke with neurological defect, when the blood pressure is less than 185 systolic and less than 110 diastolic, and they need to get fibrinolytic. And to make sure there are no absolute contraindications like head trauma, stroke in the last 3 months, subarachnoid hemorrhage, arterial puncture in the last 7 days, previous intracranial hemorrhage, active bleeding, heparin in the last 2 days, elevated INR, hypoglycemia, very large brain infarct, multilobe, platelet less than 100,000. Relative contraindication being very minor resolving symptoms, seizure may be affecting the neurological exam, surgery or trauma in the last 14 days, major hemorrhage in the last 21 days, myocardial infarction in the last 3 months. So no fibrinolytic in these two groups, and the fibrinolytic is when they hit. So in order to do that, you got to have clinical pathway laid out in your hospital so that there is no thinking involved, just check boxes and move on to the fibrinolytic therapy. There is no time wasted in it. Activate emergency response, identify symptoms and signs of stroke. Complete pre-hospital stroke assessment is very important. That will give a time for the hospital to get ready. No time of symptom onset, because that determines whether you have to do a thrombectomy or fibrinolytic therapy. Support ABCs, check glucose, triage to stroke center, alert the hospital. General assessment include vital signs, ABCs, get IV access, at least 2, obtain 12 EKG, give oxygen if hypoxemic, check glucose, always check glucose in any unconscious patient, complete neurological assessment, order MRI of the brain and emergency CT, and activate stroke team if you have one. If the patient comes with 25 minutes or less, neurological assessment by stroke team right now in the hospital. Patient history, NIH stroke scale, and last known normal or symptom onset time. It's very important. Get the CT scan done. If the CT scan shows hemorrhage, get the neurosurgeon called and transfer to the or the neurological intensive care unit or the stroke center. If you think the patient has acute ischemic stroke likely, then repeat the neurologic exam with the deficits improving to normal. Search for fibrinolytic exclusions, which we discussed earlier. Fibrinolytic therapy is still possible. Go over the risk and benefits. If satisfactory, start administer TPA, and subsequently start post-TPA stroke pathway, administered stroke or intensive care unit. Frequently monitor neurological deterioration, especially when you're doing TPA and blood pressure per protocol. So you got to have the protocol ready so that all the nurses and the providers can follow. If the patient is not eligible for fibrinolytic therapy, give aspirin, admit to stroke and intensive care unit, and follow stroke or hemorrhagic pathway. This concludes the talk on ACLS Part 2.